We'll go live now. Hello and welcome to the World Ovarian Cancer Awareness Day live panel discussion organized by Voice of Healthcare and powered by AstraZeneca. So, this panel discussion we will be talking about on the topic knowledge gap in ovarian cancer and what all should we know. To deliberate more on the same, we have an expert set of panelists here with us today. Let me start by introducing Dr. Bhuvan Chugh, who is the consultant of medical oncology at Max Super Speciality Hospital, Saket and Gurgaon. Welcome, sir.
Thank you.
I welcome Dr. Pallavi Shukla, who is the Associate Professor of Preventive Oncology at All India Institute of Medical Sciences, New Delhi. Welcome, ma'am. I welcome Dr. 𝐕𝐢𝐫𝐿 Madhavilatha, who is the Principal Genetic Counselor at MEDGENOME. Welcome, ma'am.
Thank you.
I also welcome Dr. Joy Ghosh, who is the Senior Onco Surgeon of Sahyadri Hospital, Pune, and member of 𝐸𝐈𝐌 Foundation. Welcome, sir. We also have Mrs. Rebecca D'Souza, who is the representative of 𝐸𝐈𝐌 Foundation, to share her views for this session today. She will be joining us shortly. We have Ms. Poonam Chopra, who is the patient voice for us today. She will be sharing her thoughts on ovarian cancer as she has conquered it. Welcome, ma'am. I also welcome Ms. Vaidehi Rajshekhar, who is a counseling psychologist and is our patient voice for ovarian cancer, as she has also conquered it. Welcome, ma'am.
Thank you.
Dr. Bhuvan Chugh would be leading this session for us today, so I request him to take over the session now. Over to you, sir.
Thank you, Dr. Savri, and I would like to formally welcome all of you to this panel discussion. And I think it's great that we are. It's a great initiative by Voice of Healthcare that we are trying to enlighten people about the ovarian cancer and the the worst outcomes at times it comes along with. So in the recent times in India, I think there has been a lot of right noise about the breast cancer. The way we have made a lot of advancements in the terms of making public aware about the risk of breast cancer. How can breast cancer be prevented? I think it's right. It's the time when we should start doing it same for the ovarian cancer, because it's equally deadly disease, or rather even a more deadly disease than the breast cancer. It's a cancer of an organ which is deep inside your body. The diagnosis usually is presented in a late age. Unlike the breast cancers, in which we always had that thing that most of our breast cancers used to present late, but now as more and more awareness is being created, there has been a lot of early stages also coming in. So I think it's time that we may start to make the right noise about ovarian cancer also. So with me, I have Dr. Pallavi, who is who's the professor of preventive oncology at AIIMS. I have Dr. Madhavilatha, who is a genetic counselor. I have Dr. Joy, who's a surgical oncologist, and obviously he's been operating upon such patients. I have the patient voices in terms of Mrs. Poonam and Mrs. Vaidehi, and I think they have the right experience to tell us the other side of the bench. And then there is Ms. Rebecca, who is the patient support group coordinator. So I think it's the right mix of people, and I think without any further ado, I'd like to begin. So, Dr. Pallavi, to you, you you practice in AIMS, you come across patients who probably are not. I practice in Max. I think the the different strata of patients which you both end up seeing. So I will probably not have the insight which you will probably ever be able to have. So with your experience there, what do you think? What is the level of awareness which is there in Indian community? Are people even aware that there is equal risk of ovarian cancer? What can be done regarding that ovarian cancer? You're on mute, Dr. Yeah. Dr. Pallavi, you're on mute. You're on mute, Dr. Pallavi.
Hi, thanks, Dr. Bhuvan. And that's really nice of you to starting the thread from breast cancers, because really we are very much into awareness about breast cancers and cervical cancers, because those are the things where those are the cancers where we are really we have provision for early detection. As far as ovarian cancer is concerned, the symptoms are so non-specific. The diagnostic modalities are really not available, and even if they're available, they are not yet on the guidelines that they should be in place, because they're causing more harm than benefit. So yes, about awareness, people talking about ovarian cancer, I think our population mostly who come to our center, they're not even aware of the women reproductive system. So I here would like to quote a study from Goa, which has been recently conducted, where only one third of patients they knew about something called, they've ever heard about something like ovarian cancers, and only a bleak number of people knew the reproductive system, where the ovaries are and what the kind of thing it is. So awareness is definitely minimal, and more than the awareness of people, the community, I think we really need to build up the awareness level of the practitioners, of the paramedical professionals as well, because the symptoms which are associated with ovarian cancers are very, very non-specific. So a patient might not end up with the correct kind of treatment that she should be put into. And ovarian cancer, if you look at the burden, more than 45,000 women per year in India are being diagnosed with ovarian cancers. So it's number three among all the female cancers. And looking at the mortality also, it ranks fourth in number. So definitely it is not the cancer which has to be ignored, and it is continuously on the rise. There are certain risk factors which are associated with it, and we need to talk about those as well.
So you raise an interesting point. What I've realized is, being in a corporate network from quite some time now, I have realized that there is a business sense to probably everything. The reason possibly there's a lot of awareness about breast cancer is because there's a mammogram to it, and the reason there is a lot of awareness about cervical cancer is because there's a pap smear to it. So I think for the Indian population, I think if we can, so I just don't know that. I sincerely think so. For me, the problem statement in this situation is why is there no noise about ovarian cancer? And for me, the reason there is no noise about ovarian cancer is because there is nothing sells along with ovarian cancer, as far as the prevention is concerned. So that's I probably may be being more capitalistic about stuff, but then I think sincerely that is one of the caveats which are there. So I think if we, you sitting in the Central Institute where you are, if at all we can come up with some guidelines in where we can involve the corporate or the nursing homes, in which there is some test which can be done, which probably which probably will end up making the right noises, is what I sincerely think. So you can correct me if I'm wrong. That's my journal take at it.
So yes, you are right. There has to be, these guidelines. They need a lot of data to be in place. So first and foremost, we really need to work on that aspect, that we have enough data to support that certain test will be really beneficial. What happened with the breast cancer and the cervical cancer is that we have enough studies and enough data to support that so and so test will actually be beneficial for reducing the mortality and improving the survivals. So that kind of statistics is perhaps lacking in case of ovarian cancers. So maybe that is one reason why we really don't recommend any test per se for screening for ovarian cancers.
So I understand that, and obviously having read the data, I kind of understand it very clearly. Anyway, I was just thinking for a low economic, socio-economic country like ours, I think the data would be probably separate. Probably if I don't know, I'm just thinking aloud that if I end up doing, let's say USG TVS for anybody who's, I don't know, let's probably it'll create the right noise. Leave alone if you'll be able to, make any dent in it or something. But then I think awareness, that would probably be the right way to start making awareness. So, Dr. Joy, in your clinic, do you do you see what is the proportional cases do you see? You see patients more in the stage 3 or more in stage 1 and 2? How is your clinical practice has been?
No, I think the practice in my clinic parallels what we see in India as well as worldwide. Stage 3 is the most common presentation that patients come with stage 3, in which situation the peritoneum or the cavity inside the abdomen is involved with the cancerous tumors deposits. And there are quite a few patients coming in the stage 4 as well, in which it has spread to a different site, such as the pleural cavity or some lymph nodes in the neck. So possibly, I would say stage 3 and 4 accounts for more than 80% of the cases that we see, and early cancers are very, very few.
And how frequently do you end up doing neoadjuvant methadone? So is the neoadjuvant standard practice, or you probably so? What I'm trying to understand is, for the majority of the stage 3 which come to you, is the disease bulky enough to require a neoadjuvant, or they can still be operated upfront?
So I'll put it in another way that even though if the disease on the scans might look operable upfront, most often the patient is not operable. The performance status is quite compromised. They are poor in nutrition. Most of them are elderly ladies, and they have symptoms such as ascites. They have early fullness. Their diet has been compromised for a long period of time. So they have been sitting with these symptoms for months altogether, and definitely they are not fit for something like a surgery, which is an extensive cytoreductive surgery, which is what we now do for ovarian cancers. The earlier concept of doing just a optimal cytoreduction is not there. We try to achieve an R0 in every case. So that is extensive surgery and time consuming. It's a long recovery process, and most of these patients at presentation are definitely not fit for this kind of surgery, even though they might be resectable.
So fair enough. You generally think that by the time they're diagnosed, they're so run down that it probably requires a build-up for them, which obviously includes the reduction in the extent of the disease, as well as building them up for for another 9 weeks before they are operated. So
Yes,
do you think there are any
definitely.
particular? Sorry, you were saying something. Sorry to interrupt.
Yes, definitely does help, I said.
Fine. So do you think there is any particular stigma which you have come across in your part of the country where you feel that this is what this is particularly the reason that they're these women present late, or there's something which you probably which has stuck to you that okay, why is this happening actually?
So as I said, most women are in their later ages, and they are not really. I mean, they give complaints that something is happening. They have vague abdominal complaints. They will sometimes complain of frequency in micturition. They'll complain of constipation. They'll complain of fullness after food. But then these complaints are usually given some other name. They will say nahi indigestion ho gaya, or they will say that you are an elder lady, so maybe your urinary thing is increasing. It doesn't matter. They will get some local treatment done by a general physician. So most of these symptoms are ignored. It's not that the patient is ignored, but the symptoms are definitely ignored, and they do not realize that this is something really sinister. Even in fact, ascites in many occasions is attributed to weight gain. So they will say, my feet are swelling up, my abdomen is swelling up, but then it looks like I'm just gaining weight, and people sit for even years together with symptoms such as this till it becomes intolerable, and they really come in a bad state.
So I think you make a fair point. I also do agree with you. I don't think there are any stigmas attached to it. It's possibly the vagueness of the entire clinical presentation which makes it difficult for them to be identified at an early stage. And rather, most of the times, whenever we have an early stage ovarian cancer, that's because it has been incidentally picked up. It's very, very rare for somebody to present an early stage with symptoms. And so, Asabri, if you are there, I think this is the right time to play the first video in which there is this information about the clinical symptoms. And
But tell me, how did it all start? And did you notice any symptoms earlier?
Yes, in the beginning, I had abdominal pain and digestion issues over 2 months. So I visited my family doctor to get it treated. After a few days, when I did not get any better, my doctor recommended that I should see a gastroenterologist. That is when they detected my ovarian cancer was causing the trouble. You know, Natasha, the problem with ovarian cancer is that it is a silent killer. Its symptoms are similar to common illnesses that we tend to ignore.
So thank you, and I think it kind of echoes what Dr. Joy and me have been trying to say, that it's less about the stigmas and more about the presentation as such. So we have two cancer survivors with us, which we have Dr. Poonam to begin with. Mrs. Poonam to begin with. Mrs. Chopra, if you're there, I know I personally don't like the word warriors. I think we are glorifying cancer more than a disease it is. So could you tell us what is your story? How did you get to know this is what it is, and how did we build? How did you go about evaluating it? What I'm sure there's a journey to you which I would like to bring about.
Good afternoon, everybody. I'm Poonam Chopra. Presently, I'm 71 years old. Yes, I know about cancer because way back in the year 85, I lost my mother due to breast cancer. She was detected with breast cancer in the year 82, but since she was treated
I think
in
there's some
Toronto,
connection issues. Dr. Sabri, can you just have a look at that, please? Sorry, Mr. Chopra, I think there was some disconnection. There was some connection issues in between.
all right. I know about cancer as such since I have been working, and I was very much aware because I was handling medical and everything in my company. I worked for an oil company, and I knew everything about medical and cancer surely, and especially because my mother, she was detected with breast cancer in 1982, and my brothers being in Toronto, she was treated in Toronto. In India, she was given 3 months' time, but in Toronto, she survived for 3 years with their treatment. So that was it. But my mother was always very cautious and kept telling me that I have to be very careful out of the other 4 children. And as luck would have it, I faced a similar problem. I was very regular with my checkups, and my gynae, that was Dr. Sheila Mehra. She was a wonderful doctor. And I was every year going with my regular checkups, medical checkups, and everything used to be normal. And that very year, in the year 2014, I was sitting in the washroom and I had a similar abdominal pain. The next day, again, it repeated. And then I started feeling feverish. I told my husband about it, and then we went to the doctor in the hospital, and they admitted me. And beat it, they kept me there for a month or so. They could not detect anything, and nothing was wrong. And came back home. I went to Dr. Sheila Mehra the next day, and I gave her all my symptoms. She immediately asked me to go in for tests, and which included CA125. And she asked me, she really definitely detected that there's something wrong because due to my mother's cancer, she did hysterectomy on me because I had fibroids. And she did it at a rather young age, say 39, 40, but left my ovaries. She says they are very healthy ovaries. But when I went for my CA125, she asked me, the report will come day after, you but come in the morning, empty stomach. Fine. I went after 2 days and my report was there. And she says, see, I was correct. I have to immediately remove your ovaries. She removed my ovaries immediately, and immediately she felt very sad that you are my best patient. I've been my best. I've been with her for so many years because of my children. And all. She said, "एक ट्यूब में तू फंस गई है बेटा, तू तो फंस गई. तेरी एक ट्यूब में तो कैंसर आ गया." So my immediate reaction after anesthesia was, "जय माता दी, कोई बात नहीं, माता रानी अपने आप देख लेगी." कहती क्या कहा? मैं कहा आई कांट डू एनीथिंग ना, जो करेगा भगवान जी तो करेंगे, अब माता रानी अपने आप कर लेगी, she'll take care of me. And that's it. I dozed off. Thereafter, Then she suggested I better go and visit oncologists and take my reports. I visited 6 oncos, and each one told me I have to go in for 6 chemos. But finally, I went to uh, 40s Gurgaon, Dr. Vinod Raina, which was uh, selected by my daughter. She said, "Mama, you go there. He's supposed to be very good." Okay, I went there with my husband, and he saw. He says, "Yes." I said, "This is my report, and this is this." He said, "But I don't see anything. What have you come here for?" I said, "No." And I said, "This is what it is." He says, "But I don't see anything." Okay, I'll get certain tests done. You got it done. He says, "Okay, I'll give you 4 chemos." I said, "4, but I have been asked to get 6." He says, "No, I cannot give you more chemos because yours is a low grade stage 1 cancer. And I must say, you are a very fortunate person who has been detected. The seed has just been sown and you have immediately caught it. Now, God saved me. Maybe my karma saved me, my mother's blessing saved me. I don't know. And I did go through that journey of getting those 4 chemo after a duration of 21 days. Yes, those chemos created havoc. I used to be crying all night. They were so painful. My legs, my body, and the whole night I just could not sleep. But I had my pets who would give all the solace and comfort, and they would keep on loving me. I kept them away from me. I said, nobody should come into my room. But in the morning, I would get up and they would look at me that you have to feed us. They don't want to eat from the servants. And somehow I used to get that courage and strength, and I was feeding them. I was cooking for them. I was cooking their meals, giving them breakfast, lunch, and dinner. I think that part of my journey, I think with their blessings, and it's very unfortunate that while I was improving in my treatment, I lost one of my pets, my most loved pet. So they say कि जो बच्चा कुत्ता होता है अपने ऊपर ले लेता है. But it was very, very painful. But at the end of the day, I had full faith in Almighty God and I fought for it. I said, no. The doctor, Vinod Raina, was so very happy with me. And he would ask me, what's your journey? What do you do at home? कितना बुखार चढ़ता है? क्या करते हो? लेटे रहते हो? How many maids do you have? I would say I have everybody, but I'm doing all the cooking for my family. I keep myself busy. I go for my walks. तो कितना रोते हो? I said at night when nobody watches me. I don't want to cry in front of anybody. माता रानी मुझे बहुत शक्ति दे देती है. And मैंने जर्नी अकेली जाना है ना, तो मैं किसी और को क्यों तंग करूं? ये लड़ाई मेरी अपनी है, मैं लड़ लूंगी. And today, honestly, I tell you, after 5 years, Dr. Raina has cleared me. He says today I'm cancer free. I go for my regular checkups, yearly checkups. And of course, during that course of my cancer, I developed depression. I would not let my husband go to work. मुझे डर लग रहा है, मुझे कोई पकड़ रहा है, मेरा गला कोई पकड़ रहा है. Don't leave me, don't leave me. So even his work was being affected. But slowly and gradually, I lost all my hair, yes, with 4 chemos. But that did not perturb me. Since it was winters, I would put on a woolen cap, and during the summer, I would put on another cap, and I, I was not moving out. But then he said, "No, you start going to work. Why are you sitting at home? You go to your workplace. You go with your cap, and don't bother. Don't feel ashamed. Even if they ask you, be bold enough because you are strong and you tell people how to fight with them." And believe me, I met so many ladies thereafter and who would ask me about my journey. And I would only guide them. I said, have faith in Almighty God and be brave and strong. And don't say, I can't do this, I can't do that. I said, keep working, you will forget the pains. Cry at night if you have
Mrs.
to.
Chopra, you have been very, very brave, and thank you so much for sharing with us. And it's been it's the the kind of insight you have given us to that journey which you had. I'm so proud of you. The kind of the kind of strength which you have shown. I think it's worth worth a praise, another worth a bow. Uh,
Thank you so much.
this shortest time we would like to move ahead but I think probably me and you would like to sit sometime again, and we'll try to chat in terms of the kind of journey which we can make for patients moving forward. So, Dr. Pallavi, now coming back to it, I think we, the what have been, what has been most difficult for me as an oncologist is to answer the question, cancer hota kyun hai? And what are the risk factors? And the problem is, when I look at them from a very data point of view, and the strength of association with each risk factor which comes to. So I think, like almost all cancers, the strength of association of risk factors is always an issue with me. Yes, there is early menarche and there's a late menopause. There is intake of hormone, hormone replacement pills. When I'm saying them in very top of my mind. I just in my oncologist heart, I know that the strength of association is something which I'm not very clear about. So, what do you think are the most prominent risk factors for ovarian cancer, and how do you rate them with the strength of association?
Yeah, Dr. Bhuvan. So, as we have just seen through our discussions with Dr. Poonam also, and nothing much was known to her prior to being diagnosed by a gynecologist. So even earlier we were discussing this key lack of awareness. So that is the lack of awareness among the professionals as well. So we really need to build up on that. About risk factors, not all the ovarian cancers have some risk factors related to it. But luckily, the most common ovarian cancer, the epithelial ones, which contribute about 70% of the ovarian cancers, they have been associated with certain risk factors. Few of them are non-modifiable, which we really can't do anything about that. Age is an important non-modifiable risk factor for any cancer. And same goes for ovarian cancer as well. As the age advances, you are more vulnerable to developing ovarian cancer. Another non-modifiable risk factor is having a strong family history and having a genetic predispositions. So regarding strength of association, uh, if we look at the statistics, so the lifetime risk, if we look into the general population, is around 1.6% or so. But if we look at patients having a family history, it may go as high as 4 to 7%. So that is a kind of association. And if you have a genetic predisposition, for suppose there is a genetic mutation called BRCA1. So in patients who are in family wherein there is a genetic mutation like that existing, so there are chances that around 30 to 45% of those people might be developing ovarian cancers across a lifetime. So these were the non-modifiable risk factors with that kind of strength of association. However, when we talk about the modifiable, because there are certain risk factors which we can really work upon, and that those I may categorize into two types: lifestyle factors and the reproductive factors. So lifestyle factors, obesity has been found to have a link with ovarian cancers, and cancers which are having a similar risk profile like colon cancer, the uterine cancer, the breast cancers. So obesity has a known risk potential. They say having a BMI of more than 30 could be really a strong factor for developing ovarian cancers. Then another this lifestyle factor is alcohol consumption. So alcohol has found, the studies are there to strongly suggest that alcohol is a risk factor for ovarian cancer development. Then talking about the reproductive factors, yes, as you pointed out, early menarche, late menopause, so giving that long span of reproductive years, so long span of ovulation cycles, so that is again a risk factor. What we can do about that is, yes, starting our family life earlier, because looking at the way the females are progressing these days, having more emphasis on their career profile, you really forget that work life balance. So that need to be taken care of, because not alone ovarian cancers, even breast cancers, they say if nulliparity, having no children at all, or having a children at the age of first live birth, at the age of 35 or more is a strong risk factor for developing such kind of reproductive hormone associated cancers. And another important risk factors would be, I would say, let's look at the way how what are the reasons, the theories behind development of ovarian cancers. So one of them is ki, yeah, number of ovulation will definitely have a bearing on that. Apart from that, certain risk factors which are yet not qualified as a proper risk factor is use of talc or talcum powder. So the products which we are using in the intimate areas, like the sanitary napkins, the tampons, if it is being powdered, or the talc is said to be a carcinogen
So
which
do we
might
have a study for that?
traverse
For the
so yes,
for these?
so there are studies. Yeah, so there are studies which support this view and also refute this view. So there is not a well defined thing ki, yes, we can consider this as a risk factor. So these are some of the in the gray zone areas.
So fair enough. So
So
so let me just paraphrase it for the for the sake of public. You said there are obviously the modifiable and the non-modifiable. The non-modifiable is the family history and genetic built up you have, and the modifiable is obviously looking at the reproductive history which you have. At the risk of being called as anti-liberal, you suggest that we should go for early pregnancy and actually have a childbirth before 25 or 26. But then that's what is medically proven. So I think like to move forward. Dr. Madhavilatha, Mrs. Poonam Chopra, when she was telling her story, she did suggest that her mother had breast cancer, and she developed an ovarian cancer. And I think the more and more deeper I go into oncology, I have realized that there's a job which genetic counselors do, and that's their forte, and that's identifying such patients and keeping a tab on such patients, and kind of educating the family as well as the the relatives around as to the risk which they carry. So could you just enlighten how what are genetic counselors? How can one approach them? Where do they sit? Because most of the, like, for you example, have been associated with MEDGENOME per se. We don't have one easily available at the hospital. There is obviously they're obviously now being given a separate the separate chambers in hospitals, but then they're not readily available. So what can be done? How can you tell what is the role that you can play in such patients?
Thank you, doctor. So genetic counselors, as you said, yes, are associated with healthcare professionals. We work as a team with them, but also associated with the labs which are actually offering genetic testing. So to basically about genetic counselors, we are healthcare professionals with degrees and experience in both medical genetics and counseling, and are part of the healthcare team. And we provide risk assessment, education, then support to individuals, the patients, and or their family members who are either diagnosed with a genetic disorder or are at a risk for inherited conditions. We suggest the appropriate test and interpret the result after they get them, explain the genetic test report. So and all this is actually done in a very empathetic manner. We know already there is both an emotional trauma and financial burden, not only in malignancies as such, but any genetic disorder. And for this particular, so the along with the knowledge of genetics, so genetic counselors actually we have knowledge in genetics, molecular biology, and a little bit of psychology also. So we simplify the language of genetics, explain to the patients and their family members. So there are good communication skills that are required. We address the patient concerns on about the genetic disorder, about genetic testing, and keeping in mind certain ethical issues also, so that they can take an informed decision about genetic testing, and about when a clinician recommends a genetic testing or the management or the treatment based on the genetic test. So yes, counselors you can find in with the hospitals where the
So
test is
precisely, I was
advised.
about to ask, how does one reach out to you? As in, so if they have to depend on a clinician to reach out to you, I kind of, I sincerely think that there has to be a via media to somebody to reach out to a genetic counselor. If I am worried that I have a family history, like if somebody is worried they have a cancer, they have me to reach out to. So like if they are worried that there is a family history, they should have you to reach out to. So what I'm asking is, how does one reach out to a genetic counselor?
As of now, yes, the clinician is the first person that they approach. Then the second is the lab where the test is being done, and even academic institutions wherever the test is offered. Because almost all of these tests that we are talking about, doctor, they're all diagnostic tests, and they're not direct to consumer testing. So they actually come through the clinician, through the hospital. So the two options available to them would be coming through the clinician or through the hospital, or identify a lab. And then yes, there are genetic counselors who are freelancing also, but again associated with the clinic or the individual clinician itself. So that's how they can actually approach us, directly calling the company where offering there is a genetic testing offer, who, as you said, we offer counseling also, or talk to the clinician itself. Definitely yes. So we actually reach out to the clinicians. Many of the times actually what happens is, as you said, the patient might not actually, the person who actually approaches you might not be actually showing the symptoms. They would be either in a pre-symptomatic stage, they would be a relative or a friend, and then where you need not do a diagnosis as such, but they only need to have counseling. Definitely you can send them to that these are the places or people who are associated or can offer counseling, and please recommend them. That's all. And that's the only way, that's the best way I feel, coming through the
Kind of.
clinician.
I think you're right. So basically, what he's saying is, the clinicians are the point of contact, and then they should be involving you in decision making, is what it is. And I think it's a fair point. So, Dr. Joy, shifting gears, most of the patients which you see in your clinic, and once they have operated, and so do you feel that there is a, before I move to Mrs. Rekha, I want to take your view as a clinician. Where do you see the strength of a support group? So when do you attach a particular patient coming to you in a support group? Is it at the beginning of their journey? Is it at the mid of their journey? Is it once they have finished their treatment? Would you want to send them in support group? How does it work with you as in your clinic?
Right. So I would say the strength of a support group is at every step of the journey that a patient faces. We are lucky to have Mrs. D'Souza with us as an in-house or on-panel counselor and a psychologist. So she is someone who coordinates the support groups as well as takes the patient from the clinician into the journey to become a survivor or to go through the journey of cancer treatment. We saw Mrs. Chopra describing her treatment as quite painful. Many of them have a lot of side effects, and I feel that the earlier the better. If you can possibly refer your patient or get your patient to see a support group or to see a counselor who can guide them to a support group, it will help them from day one of their journey. But to be realistic, this doesn't happen every time. The patients first come with a diagnosis which is lacking. I mean, first of all, they don't come with a diagnosis. Once they do get to know that they do have cancer, many of them have a significant trauma in the beginning. They feel that their life is in jeopardy, and their loved ones are, they are going to face some kind of loss. So this is something that is very difficult to get over and to get them on the right path to treatment. So this is the initial challenge, and in this also, if the patient does wish to, go ahead and consult some counselor, or we do recommend that you can meet some other patients who either have been treated or are undergoing treatment to know more about their journey. It's very very helpful to make a patient understand what they need to go through. And I do think that yes, the word warriors is right for these patients, though I don't want to glorify the disease, but it's definitely, I would say that they do have to put up a fight because they do have a lot of significant side effects. So I'll let Mrs. D'Souza speak about the support groups and how they function in the foundation.
So fair enough. I think you raise a fair point, and being at Max, I think we have the biggest support groups programs in the country, and I think the way we and the strength of a support group is it's something which I've realized that once I came to Max, I realized that what is the strength of a support group? It's the daily aches and pains which somebody also has gone through, and there's somebody to support you in that journey. So what my practice is, I generally introduce the support groups when I admit the patient for the first chemotherapy. I give them a hint that this is where there's entire support group, and I leave it to them that whenever they want to, reach out to the support group, they'll have the number of the coordinator. So, Ms. Rebecca, I think you are the right person to understand, the strength of a support group. What is a support group? How important is it for a particular patient in the cancer journey? How can it make it so much more painless and so much more supportive? So, could you please enlighten us? You're on the mute, Ms. Rebecca. You're on mute.
I said, thank you for the opportunity. I think I'm the last moment entry. I'd just like to talk about the first point that you made, that there is so much of emphasis on breast cancer, that the rest of the women's cancers especially is out of sight. So there's nothing structured for them. So even at the foundation, our focus has been a lot more on breast cancer, but we've also included all women as a part of the support group. So we couldn't have a disease-specific support group. We have a support group that's open to all women. For men, we are in the process of looking at how we can start to begin. So, like Dr. Joy said, there is a counselor or a mental health professional available at the daycare itself, which is like it's not based on a referral. We don't really wait for the doctor to refer to us. We take a round, we talk to every patient, so they are comfortable with us. There is a rapport built. And then we also become the intermediate between the patient and the doctor. The problem that we have faced is very often, especially with ovarian cancers, with older women, they are not told their diagnosis. The family doesn't want them to know what they're undergoing. So that becomes a little difficult, because if we put them into a support group, into a structured program, they may know the diagnosis, and that becomes a big issue. Because so although we try our level best to convince the caregivers that it's the patient's right to know what she is undergoing and why certain things are happening, because you can't avoid the side effects of cancers. So the way the foundation works is we have two modems of a support group. We have an online support group program also, where we organize lectures, we organize fun stuff online for people who cannot join, because we have patients not only from Pune, from where we operate, but even surrounding areas. And we have an offline, or we have a personal one-to-one interaction. And it's not only about sharing the smaller journeys or the smaller aches that take place, but it's about people who have gone through it telling you that, boss, this is it. It's happened. Don't make it the focus of your existence, of your life, and just to move on. So they become a lot of encouragement, a lot of support that they get over there. They get a lot of even small tips on how to handle side effects, on what to do when your port is infected. And I'm feeling like giving up. I mean, we just had a woman last week who posted on our WhatsApp group to say she doesn't want to continue with chemotherapy. And she hadn't spoken to the doctor yet, but it was the support group members who kind of pushed her and said, listen, talk to me. And they would call her. So the support group is very integral. And it becomes a part of the whole survivorship program. So we have a nutritionist also who's involved. We have access to a genetic counselor also who works pro bono. So whenever there is an issue, because there are so many times that they don't talk to doctors about certain stuff. And so we have associated with somebody who also helps them deal with their sexuality, especially with younger women. It impacts their sex life. So they want to talk about it. They don't want to talk to a doctor. This is a very comfortable platform that they are speaking. They're able to communicate whatever they are feeling.
So what you say is absolutely right. Sorry to interrupt. I think what you're saying is absolutely right. So it takes away a lot from the, it's a lot of support to the primary caregiver also. So when you have people going through the same experience, hurrying behind you, and they are obviously trying to move you into the right direction. It provides an inherent support and inherent strength to a person to just carry forward. And I think you make a very fair point that when it comes to a support group, it's an essential part of survivorship. There is nothing which beats the human connect which a patient forms with another patient, and in the suffering, and then make decisions which are good for them. So sorry to
I
interrupt
just
you.
like to
You're
add,
saying
I just wanted to add one program. I mean, a point. Sorry. Um, an offshoot of what we started off as a support group with, but what an offshoot was that we trained certain of our survivors, about 12 or 15 of them, who before COVID would make a visit compulsory every day at the daycare. So the moment or at the OPD, so if there was a new patient who was diagnosed, after talking to the medical professionals, they would be referred to to this survivor volunteer, and she would be able to put it in a better perspective, and so that journey is from the beginning till the end, and then they don't just leave the support group. We have patients, I mean survivors, who are like 23 years down the line, 20 years down the line, and they are there motivating people. So we also have a matched program. We try to match uh, to a patient with a survivor according to age, again according to stage, and so forth.
I think this match program is something which I would like to take back to my support group also. I think it's like a mentor-mentee thing which could happen. But anyway, moving
Especially
forward,
when you
I
have
think
young patients.
yeah. So I think moving forward, thank you for being patient, Mrs. Videhi. And so coming to you, you have been a survivor yourself. You obviously support patients. So I think it's time that you tell us your journey, the way you found out, and what was it that made you go to the doctor. How has this journey been emotional to you? What have you learned? What have you gained out of this journey? So please, enlighten us.
So thank you for giving me this opportunity to speak on this panel, first of all. My journey started as if like my nanny was diagnosed with lymphoma back in 89 when I was just 9 years old. And we lost her due to that. And that time, first time I heard in my family that there is something disease called a cancer, and it takes away life, something like that. Then my mother she's also a cancer survivor, a ovarian cancer survivor. She was diagnosed in 2015, and she's also surviving till now. I was diagnosed in 2018 due to acidity. Like I was suffering from an acidity, but as Dr. Shukla mentioned that we don't tend to go to oncologist immediately, because it was just a small thing which we often come in our regular life. So being a layman that time, being a non-medical person, it never occurred to me like I might be suffering through this kind of a disease. So I went first to my physician, a regular physician. So he treated me, but then the acidity started. But then when I went to my a family surgeon, he suggested me to do the CT scan. Then he suggested me to do the CA-125, and that is the way I was diagnosed. So before, so that was something which was a bit hilarious incident which has happened. So CT scan was done, and I was like, so before my journey started, I had seen my mother's journey. So I knew how that is gone, because that time I was a caregiver, I was taking care of her. So I knew the side effects and everything. So till my CT scan happened, till my CA-25 comes, I did not know that I'm also suffering from a same disease like my mother had. So I asked the technician of that CT scan person that what are the reports like after the CT scan. He said, kuch nahi, cyst hai. So I immediately asked him, malignant hai kya? So he was like, why she's asking me like that? So I said, please, I don't get afraid, because my mother is also with the ovarian cancer, so you can tell me. So he was like, no, I will put it in the report. So that time only I came to know that something is fishy is there, because they usually don't tell. So I came home, I went to my mom's place, and I was like, Mama, it's same pinch. I think I'm also going to fall for the same disease which you. And then Monday we visited the doctor, and in between I had a lot of thoughts like, क्या होगा, maybe pancreas का कुछ problem होगा, या liver cirrhosis नहीं होना चाहिए. And I was thinking all these things कि क्या नहीं होना चाहिए sort of. And I went to see my surgeon. He's Dr. Sachin Waze. He practices at Jahangir, Pune. And I was like, "Ki, this is my CT scan report, and what has happened? Kya pancreas में कुछ हुआ है ऐसे?" So he was like, "नहीं, no need to worry at all. कुछ pancreas में problem नहीं है, liver cirrhosis नहीं है, as you're saying, you just got an ovarian cancer, but हम लोग उसको treat कर देंगे." And I was like, "Oh, what is he saying?" I was like, I could not, talk for 5 minutes, and it was like, then he wrote me the test, CA-125 and all. The first thing, I came out of his cabin, I started crying like hell. I was like, what is this? What is happening to me? And so basically, when it happens to us, like, now I'm being a psychologist from past 10, 15 years now, but then when it happened to me, psychology, everything was gone that particular moment, everything was gone haywire. I was like, okay, fine. Then it took me a day or two to come back to, at least to a normalcy and think. But still, I knew the ifs and buts of the cancer because I have seen my mother's journey. I knew it's going to be a nausea, it's going to be vomiting, it's going to be a lot of, it's going to be a lot of weight problem. It's going to be so daily small things, which regularity happens in the normal people, healthy people. It's not going to happen with me anymore. So I was like, I knew, but when this treatment started, then I was given a plan of, I had been referred to Dr. Shona Nag, and that's it. She had become my oncologist, and I have been taking treatment from her since. So I was being given the surgery option also and the chemo option also. I said I will opt for both because it was like doctor's decision ultimately, usually, because they do best for you. So my thing was like, okay, fine, they are doing good for me, so let me have faith on them. That was my thought, which somewhat pulled me through also, because इसमें खुद को दिमाग नहीं लगाना पड़ता है. It's like your doctor, he's thinking best for you, she's thinking best for you. Let her have the headache of you. You don't need to do that. You just need to go. But when treatment started and the side effects started happening, so I had really the emotional turmoil started, because being a patient, you are under constant fear of a constant fear of what will happen, how my next day is going to be, how my next day of, like, that is the thing which happens all the time. And first two chemos, I was really in bad shape. First two chemos which happened to me, I was really bad shape. I didn't know what to do. I was like, okay, fine, ye ho raha hai. I could not move also. I lost a lot of weight. And then I had to gather myself. I was like, okay, fine. Then I went, I met my mentor, who is a counselor. I said that, mera dimag nahi chal raha hai, aap theek karke de do, sort of. Because I had to stand up. I had to face that. I had to face the surgery also. I had to do the surgery also. So then I had taken a counseling, and slowly, I came back on track, and I realized one thing which was very, very important during the cancer treatment and after the cancer treatment also, because my cancer has been reoccurred last year again. I'm cancer free now. Again, I'm leading a normal life. It's like so. So I understood that particular time that what fear we have as a patient, as a human being, is the fear of uncertainty, because we follow a certain pattern of our life till we are diagnosed with the disease, and after that everything is changes, and we struggle back to go back to our previous life ke pehle jaisa kab hoga. That is something like we seek, and most of the cases, or I would say 50% cases, it might happen, 50% cases it might not happen. It depends upon every individual. So it took me a lot of time to realize that what was a fear of, like, we have the fear of uncertainty. Uncertainty. That is something which
something which you told me which has really stuck to me is the the realizing that this might be the new reality and accepting that. So what I have realized as an oncologist is that it's so much necessary that it's not only the chemotherapies, it's not only the disease, it's the constant conversation which you need to keep having as an oncologist with your patient.
Yes.
You need to
Yes.
understand the disease and the patient both. So
Yeah.
there is this need to constantly understand that what the patient disease is, how do you want to treat it, and then what else is required to make the patient better. It's not only the drugs, it's also to essentially understand the body makeup of the patient, the nutrition which the patient want to go through, the emotional crisis the patient is in, because I think a positive mindset does have a lot of effect on it. I have this soft thing, or rather a strong thing of keeping the caregivers involved, and also not letting them get overburdened with when it comes to cancer treatment, because I think their life and their careers are also important, and the patient also has to live independently. However, you can't take away the caregivers from them. So I generally believe in having a very open conversation with the patient, at least to understand that this is what your name of the disease is, this is what the stage of your disease is, and this is how fit you are as a patient, and this is what we're going to do about it. Each time we do something about it, there are going to be a few ups and downs, which you need to be openly communicating about it to me or my team. And that's where you and me are going to be tweaking your treatments up and down about it, and you'll probably end up on the other side of it cancer free. But yes, the goalpost of your life may change. The goals which you had set in your life as a thing that I will probably be doing this at that time may change, and that's a constant conversation you need to have with yourself as to what is important for me at present in life, and that's where I am. Anyway, so moving forward, Dr. Shukla, if Dr. Shukla, if you can just give us these last comments as to what can be done to prevent cancer, and then probably would close the session.
So, since we don't have any specific risk factors pertaining to ovarian cancers other than those which we already discussed, which are linked with the epithelial tumors, we what we can do in this particular cancer goes well with other cancers as well, like having a healthy lifestyle, working out, a good exercise schedule, at least 30-40 minutes of brisk walking or running or any kind of moderate level exercise, at least 5 times a week. So that kind of regime one should really incorporate in the lifestyle. Maintaining healthy weight and eating a good variety of nutritious food involving the dietary fibers, the colorful vegetables and fruits in your diet, and staying away from processed food, the beverages, these aerated drinks. So these are the things that we just talk about it, but in the hindsight, if you see, these are the factors which are really working. So maybe these were the factors which really helped us as an Indian when we were not so much into cancer rays as we are right now. Apart from that, knowing your family history, no doubt it is a non-modifiable risk factor, but it is very important that you know what happened 2 generations ahead of you and what is happening in your cousins and nieces and nephews. So that will actually give us an idea as a practitioner as to which way to go through, because genetic factors definitely have some role to play in many cancers, and and as the science is progressing, we'll get to know more such linkages in future. So right now also we have 2 survivors with us who have family histories. So that way we really need to be cautious about that. And the other thing that I would say regarding cancer preventions is, particularly in reference to ovarian cancers, is ki, why, Dr. Bhuvan, what is your call on taking OCPs? Because OCPs have also found to have a protective role in case of ovarian cancers.
So I think it's a thing. I personally, as a barrier method, oral contraceptive pills, it's a personal choice which most of us end up having. and it's a choice of a female what barrier method they want to use. I personally, I don't I don't go about prescribing it to them because it's generally not my clinical practice. It doesn't fall into my clinical practice, and I probably leave it to the gynecologist to understand and to advise that to a particular patient. If a patient barrier choice method is a OCP, I probably would add that it may help prevent cancer also. So if you're inclined towards it, this is what extra it can do for you, and that's where my stand is. I think there are certain questions I've just gotten. So do we have time or are we about to close, Dr. Savri? I think we are about to close, is it?
Can we take this one patient, one question, because it happens very often. The one on PCOD. If Dr. Joy could just give us a little whether
Yeah,
PCOD
Dr. Joy,
also.
I think you can give that thing. I have PCOD or PCOS. Should I get checked for ovarian cancer as well?
Yeah, so to answer that question, PCOD is a disease or illness which affects younger women usually. It starts from the second to the third decade and ovulatory cycles. So PCOS by itself, or you can say PCOD by itself, is not known to be a prominent risk factor for developing ovarian cancer. But many of these patients do have unovulatory cycles, as in their ovulation is disturbed. And because of that, there is a slightly higher chance due to that for that other factor, which is the ovulatory cycles being disrupted and not PCOS itself. So there is maybe a higher incidence of ovarian cancer, but it does not mean that these patients need to be systematically screened for developing cancer. They can be, they can undergo a health check or whatever, a systematic workup, maybe at their middle age, starting in the middle age, or if they have a strong family history. But they are not at a higher risk of developing ovarian cancer as compared to the general public, or not at least in a significant way.
Fair enough. I think can we so Sabri, you need to tell me how much time do we have so that we can decide whether we want to take more questions or not.
So, sir, we can take one more question and then we can end the session as we are already over time.
So I think they had 3-4 questions in terms of there's this Miss Gunkaur asking ovary removal the only treatment for ovarian cancer. I think Dr. Joy, you can take that and we can close the sessions after that.
Yeah, so today we don't consider a single modality treatment for ovarian cancer, as in we don't use only one form of treatment, which is either surgery or chemo for treating ovarian cancer. We use something known as multi-modality treatment. The best outcomes can be got by using all the possible treatments available to us to reduce the chances of a recurrence. So a majority of these patients will require chemotherapy as well. But you are right in saying that surgery is the mainstay for a curative treatment for these patients. If the patient is in a curable stage, then yes, at some point in time, either before starting chemo or after some cycles of chemotherapy, definitely surgery is required, and not just ovaries. Significant tissue from the abdomen is removed to clear you have to clear the entire disease from the patient. You cannot leave even the smallest amount of disease behind. So it's an extensive surgery which does involve removal of the ovaries, but also most of these patients will require chemotherapy as well.
So I think what point Dr. Joy is making, I think what is the rule now is a multidisciplinary team discussion, and I think for every cancer that's the norm to go to. There are tumor boards for every particular disease, and the treatment plans are drawn out. Obviously, the surgery is the central part of ovarian cancer. There is no doubt, and it's supported before and after by chemotherapy or after by chemotherapy. And I think the way you give chemotherapy is it's the way it depends upon what are the adverse effects of it. Obviously, there are drug-specific adverse effects, but there are also supportive medicines which are given, which generally help the patient tide over the crisis or tide over the adverse effects which generally have. So I think that's where the art of therapy lies, is what I'd say. I think so. It has been a pleasure to have all of you on the panel, and it has been, I think, an enlightening discussion which you've had. Thank you, Mrs. Poonam, and thank you, Mrs. Vedahi, for being there and sharing your journeys. It's been an honor to listen to your journeys. Thank you, Mrs. Rebecca, for giving us insight into a support group and introducing me to the concept of matchmaking, which I'll probably end up doing. So, and thank you, Dr. Madhavilatha, for being there. And I think we should have more and more exposure to the genetic counselors. I think they are an essential part of a cancer network, and I don't think there's any denying anything in that. And thank you, Dr. Joy, for being the surgical oncologist on the panel. And as we all understand, the surgery is essential to any ovarian cancer. So I think, as so moving forward, Dr. Pallavi, thank you so much. You have enlightened us about the prevention aspect of it. And thank you, Sabri, for this opportunity. Lovely being here.
Thank you so much, sir, for so expertly leading the session for us. And I also like to thank all our panelists for taking out time from their busy schedules and sharing this immense wealth of knowledge on World Ovarian Cancer Day. I thank all the viewers as well for staying us till the very end. And in the end, I would like to sign off by saying stay healthy, stay happy, and stay joyful.